So it's a great pleasure for me to introduce to you our keynote speaker, David Lebwohl. And I was reflecting on the conference. This is my third time co-organizing this conference, and I believe, Mano, I think you were our keynote speaker in 2019, last time we were on campus. In the evolution of that talk about oligo siRNA therapeutics and their rise to commercial and real patient benefit in the marketplace, followed by the virtual conference 2 years ago where we had Phil Dormitzer talk about mRNA vaccines, which was very timely, I think a month or two after the initial clinical data read out, which was a meteoric rise of that technology. And similarly, in terms of trajectory, what we're going to hear about tonight is CRISPR-based gene editing in vivo in patients. And that's remarkable. I think some of the common threads are that this technology and some of the delivery technologies, lipid nanoparticles, other things, kind of build off of each other. So this truly is an ecosystem that's feeding into the creation of new nucleic acid therapeutics in many different ways that we couldn't have even thought about 10 years ago. So really excited to see this, David's talk, and a real appreciation for David giving this. By way of introduction, David is the Executive Vice President and Chief Medical Officer at Intellia Therapeutics. Prior to Intellia, David was at Semma, where he was also Chief Medical Officer. The career move was a good one. Semma was acquired by Vertex. And prior to that, David was at Novartis for many years, including working in CAR T therapeutics and development of some of that technology, cell and gene-based therapies and technology. Academic background, Harvard undergrad, Yale Medical School, residency at Brigham and Women's, and then on to Sloan Kettering before joining industry. So a very enviable CV. So David, we're really thrilled to have you. Thanks so much for coming and giving this talk.
That's great. Thank you, Matt, and the co-organizers for inviting me here. I'll be speaking about what Intellia is doing with CRISPR genome editing. Of course, there are many companies working in this area, but I do want to talk about some of the early successes that we've had, particularly in the area of in vivo editing. Some disclaimers. I can't read it either, but none of the drugs you'll hear about today are approved yet. They're all in investigational drugs at this point. So this is where we think of ourselves as a company, two aspects of using CRISPR. One is to use CRISPR to modify cells outside the body, so ex vivo. This is being directed mostly so far towards immuno-oncology, towards autoimmune diseases. I actually won't talk about this very much today, but it is one of my first loves coming out of the RT program at Novartis. And if you see me this weekend and want to talk about that, I'll be glad to. I will focus on in vivo therapy, where CRISPR itself is a therapy. And this is all based on a modular platform. So, the aspects of that, I'll be going into the different, there's obviously the editing tools that you need and the delivery tools. In terms of what we have for editing tools, of course, the CRISPR-Cas9 in various forms with different advantages based on size and specificity, doing base editing. We are finding this more valuable on the ex vivo side. So again, I won't talk much about that, but an interesting technology for doing multiplexed editing and knockouts. And then DNA writing. And we recently acquired a company to help us move this forward faster. And of course, this is an exciting area, but still very early in terms of getting to the clinic. On the delivery side, we use LNPs. Now everyone knows about LNPs, which is good. I guess you guys knew it before, the rest of the world. But of course, for delivering vaccine, and in this case, you'll see delivering our drug to the liver. We also need AAV in some cases. In this case, for contributing DNA when we're knocking in a gene, which I'll talk to you about. And of course, there may be other ways to affect delivery, especially when you want to get outside of the liver. What is the potential of CRISPR? Of course, here we're getting at the core of disease in many cases, getting to the exact gene that's causing the disease. And then you'll see how that's working in the two cases we've gone after so far. And it takes a single dose to do the therapy, potentially, if you have the right dose, that you can get a complete effect just with that single dose, and it will be permanent. Third, ultimately, it can reduce the burden of the healthcare system in terms of costs, and I'll talk about that a little bit more for some of the therapies. So far, where we've been able to deliver to is the liver. An important piece of this, since we're using mRNA for the CRISPR-Cas9, this is very transient. The mRNA and the protein are gone within a few days, so there's no potential for additional editing after those first few days. And using a guide RNA to get the accuracy and precision. And a lot of the work in terms of the safety of this is to spend a lot of time to choose the right guide RNA. You can get the high precision and edit the genome at the intended site. And in this case, either knockout to get rid of a protein that's deleterious to the patient, or to knock in a protein that they need to correct a missing protein. And that target site is conserved across the patient population. Now, how do we avoid off-target? And this has been a very big issue in the field. If we're cutting DNA at a single site, how do we know it's not cutting elsewhere in the genome? So a lot of the time is spent before you get to the clinic, first with computational effect of finding a site, looking at multiple genomes, including different structural variants, and then doing extensive testing of that guide. And that testing includes both looking for on naked DNA to see any site that even with high concentrations of guide and protein that you could edit, and then looking whether any of those sites that you hit with that on the naked DNA, are they validated in cell types? And again, we push the dose of the CRISPR and the guide in order to see, when you push it, do you see any of those sites outside of the main target site being edited? Now, what's special about CRISPR, of course, as compared to other enzymes, is that it's only active when it's with the guide RNA at the appropriate site. So challenges possibly with things like base editors or other enzymes is that they are active constitutively. In this case, what you know is that it's only going to be active at the site, which is important for avoiding the off-target editing. This shows our pipeline of things that we're working on, and I really won't go through this, but you see sort of the range of things. We were working closely with Regeneron, so I will be talking about TTR amyloidosis, which is a project in collaboration with Regeneron. Also, Regeneron is taking the lead on the hemophilia programs. You'll see this is a knock-in program like our alpha-1 antitrypsin program. And I will talk about some of these in vivo programs in more detail. So in this case, for in vivo, CRISPR is the therapy. By using a non-viral delivery, we think we avoid the issues of having the virus, the Cas9, expressed over a long period of time in the cells. And of course, there's the potential of permanent gene knockdown or permanent gain of function. This is what the drug itself looks like. So it's an LNP, which includes messenger RNA for CRISPR-Cas9, and in addition, the guide RNA. Advantages of an LNP. Of course, there's a lot of known use of LNPs already in drugs, so well characterized both in terms of safety and in terms of delivering to the liver. And they do have a large cargo capacity, so potentially the doses of LNP would not have to be high. Mentioned transient expression, can't overemphasize how important that may be, that you're not going to have the protein there for very long. Also important is that it's not immunogenic. Unlike viruses, which AAV, as you know, patients may have pre-existing antibody, or once you give an AAV, you really can't give it again because they develop antibodies. In the case of an LNP, there's nothing significant to develop an antigen there. There's no protein expression of the Cas9, obviously. It's just the messenger RNA. And this leads to the possibility of being able to retreat with these drugs. And, of course, when we say it's one time, you don't think you need to retreat, but you can imagine circumstances where you may want to titrate the dose over time, and then the ability to retreat could be valuable. Let's start with the disease ATTR amyloidosis. In this case, what's happening is TTR is a serum protein that accumulates it gets in the mutant form particularly, or when you get older, in older patients, it will accumulate in the organs. So it becomes misformed and will affect the nerves in the case of the mutant, and as well as the heart, and the effect of wild type affects really just the heart. For other therapies that are available so far, they do require chronic and lifelong therapy in order to knock down or to stabilize this protein. So what we hope to do with this is to knock out the TTR gene with a single dose of CRISPR-based therapy. It would affect both wild-type protein as well as the mutant protein. And it would address both types of disease, both polyneuropathy and cardiomyopathy. Now, the advantage we hope to see with this is not only that it's a single-dose therapy, but with gene editing, could we get to lower levels of TTR? And we'll look later at what lower levels of TTR might do for patients. A little bit more about the diseases. On the left, you see that with the variant, that's the mutation, it's actually a relatively rare disease, about 50,000 patients worldwide. But the wild type is actually a very common cause of heart failure, and in this case, up to as many as 500,000 patients worldwide. The life expectancy is relatively short. The variant is a more aggressive disease, more rapidly progressive, but as well, the cardiomyopathy, because it's involving heart failure, patients die earlier due to that. And imagine the symptoms you have with heart failure. This includes shortness of breath, in terms of the nerve effects, muscle weakness, and sensory deficits. Now to the editing. So this is looking at editing in cells, in human cells. In this case, we're going across the bottom at higher and higher concentrations of the guide RNA, and that looking at what is the frequency of editing. And when you get to physiologic concentrations, EC90, which we wanted to achieve in people in order to get 90% of the alleles edited, what you see is actually very complete editing at a concentration of, there you can see, 0.57. Now, even when you go to threefold, there's really still no detectable off-target editing. These are looking at the sites that were defined by the earlier work I talked about, where you're exploring the genome. And even if you push it very high, you start to see a little bit of editing. What's important about these sequences as well when we choose the guide is it doesn't involve any genes that we think could be troublesome if they are edited. In general, it's hitting intergenic areas or introns. And of course, we would avoid any type of oncogenes or suppressor genes that might be troublesome if you did edit them. And this is how it works. It takes up APO3 in the serum, so it binds to the LDL receptor in the liver. It's endocytosed, releasing the messenger and the guide. Of course, the message is translated, so you get a ribonucleoprotein which is a complex of the Cas9 with the guide. That enters the nucleus and very specifically targets a single site on the genome, in this case, the TTR gene. With that, you get nonsense, you get indels and nonsense mutations, and what you see is that it no longer produces protein. This was first shown in non-human primates, looking at various concentrations, control on the top, and then increasing concentrations as you go down. And what you see is within a month, you have really stable reduction of the TTR, essentially going to really 90% or greater reduction in TTR, and that is completely stable over the time that the animals are followed. And you can imagine we did expect this to be permanent. You are changing the genome, and we haven't really figured out a way that this would be able to come back or be corrected in the animal, so that we do expect that to be a permanent effect for the lifetime of the animal in this case. We then took this to clinical studies in 2020, starting out in the pandemic, but sites actually did a great job despite that. And it was a two-part study. The first part was to study in patients with polyneuropathy. We started there because these patients are healthier, as I mentioned. They have neuropathy, but they don't have a life-threatening disease early on at all. And then, and you don't want to, as you give a drug, you don't want to confuse any of the complications of the drug with being a complication of the disease itself. That could be complicated. So it is good to start with patients who are relatively stable. When we established the dose and the safety in the patients with polyneuropathy, we then moved on to patients with cardiomyopathy. Just to show those individually, these were the dose levels. We started at 0.1 milligram per kilogram based on the non-human primate studies. It was 1/10 the no AEL dose, and went up in increments 0.3. Actually went from 0.3 to 1 milligram. And then because 1 milligram seemed to be the top dose, we didn't want to have that sort of threefold gap in there, so we went back to 0.7. In part 2, we dose expanded at a fixed dose based on the kilogram-based dose. What we had found in part 1 is that weight was not important in terms of determining the exposure of the patients, so that you could use a fixed dose and get very similar exposure across all weight groups. We're also interested in clinical measures of neurologic function. This actually takes a long time, so I can't show that to you yet today, to measure the changes in neurologic function, but we hope to report that later in the year. We then moved to patients with cardiomyopathy. Because we had seen very good safety at the lower doses, we were able to start at 0.7 milligrams and just have two doses, 0.7 milligrams and 1 milligram, patients with different degrees of heart failure. And then in dose expansion, after what you'll see, we went forward with 55 milligrams. Here again, we will have clinical measures of the disease, but again, this takes a while to follow through, and the patients have been treated relatively recently. In terms of safety, it is very well tolerated. We had dose 27 that we reported publicly. We've also said publicly more than 50 patients have now been treated because we've gone on to part 2 of the study. And what we've seen continuing is that the majority of adverse events have been mild. The one thing that does seem related to the drug is what's been seen with lipid nanoparticles as a class, and that is infusion-related reactions. The patients get what looks like they get maybe flushing, they get back pain and other things related that seem to be a reaction to the LNP itself. All the patients have been able to get their complete study drug. None of them have any clinical sequelae beyond the time of the dosing. And we did not go as high enough to achieve a maximally tolerated dose. We decided, as you'll see, that we had saturated and stopped at 1 milligram per kilogram. This shows more details of the adverse events. And for your understanding, grade 1 are mild events, things like a slight headache or in cases that are here, some slight back pain. Grade 2 is somewhat more moderate type of effects. And grade 3 would be severe effects. You could see there was one grade 3 effect in the patients at the higher doses. In this case, it was not clear that it was related to the drug, but maybe related to the patient had autonomic changes, which may go in line with some of the pre-medications they were getting for the therapy. And again, these all resolve completely after a few days. Similarly, for cardiomyopathy, where we thought this would be a more difficult group of patients because they are somewhat decompensated from their heart failure, you can see that they also did very well. The one grade 3 event was related to an infusion-related reaction where the patient, because of had lower blood pressure and a patient with heart failure, that can be troublesome, so they were watched in the hospital overnight. And here's the effect of the drug in patients. So this is looking at the various doses. At the first dose level, we already saw what was 50% reduction. For reasons of other drugs they took, it actually went up a little over time. But when you got to the higher doses, what you see at all 3 doses is very deep reductions in TTR, and particularly at 0.7 and 1 milligram, getting down to 90 to 93% reduction in the protein. This occurs within a 1-month period. You sort of reach your nadir just in 1 month. And again, now this looking out 12 months, but now looking out even further, this is looks like it will be a permanent effect. It's very long-lived. Patients with cardiomyopathy had an even more consistent results. In this case, the reductions range from 92 to 94%, and you can see the standard error is very tight in these patients. So what's very interesting is that you get what looks like a saturation of the effect at 0.7 and 1 milligram. They look about the same, and that for almost all patients, that leads to a very deep reduction in the TTR. So this would be, the fact that you have to only give this once is attractive, but it really is not the most important thing for the patient. The most important thing for the patient is the efficacy of the drug. And so the goal of getting to deeper reductions in TTR is shown for this reason. This is data coming from another drug, patisiran, done by a New England Journal article from Dr. Adams. And what they showed is that as you go down in TTR, and these are proportions, here 50% reduction, 70% reduction, 80% reduction, 90% reduction. As you go down in TTR, you get improved clinical effect. This score going downwards is an improvement in the patient's neuropathy. And what's quite interesting is as you get to those very deep reductions in the 90% range, you start to see a more than proportional benefit for the patients. Now, this hasn't yet been shown in patients with cardiomyopathy because these drugs haven't been studied extensively yet in cardiomyopathy. But in cardiomyopathy, the same effect has been seen with light chain disease and other types of amyloidosis. So it's felt that the same effect will be seen in cardiomyopathy, that you'll get a better effect as you get to the lower levels. With this drug getting to 90% or greater, this is different from many of the available drugs, which get about an 80% reduction in TTR, and you can see a much less consistent effect. You can see that the TTR ranges from 20% reduction in the active drug to the greater than 90% in a small number of patients. And this is the placebo shown over here, having no effect on TTR levels. So this program is moving forward to, we've completed the phase 1, as I mentioned. and we're moving now to phase 3 study to prove the benefit of the drug. First, for patients with cardiomyopathy. This will be a large study in which patients either get the drug or get placebo, as well as standard of care in all cases. And the endpoints of this are looking at cardiovascular events and mortality, showing real benefit for the patients. In polyneuropathy, again, we would do a study looking at this mNIS score and trying to achieve these kind of reductions in the mNIS score that would be predicted by the reduction in TTR. Move next to hereditary angioedema. This disease you probably haven't met anyone with. It is quite rare. It's characterized by recurring, severe, and unpredictable swelling in various parts of the body, also causing pain in some cases. And there's some very good therapies already. They all require either a daily oral medication, which is not quite as effective as some of the drugs given intravenously. But the intravenous drugs, obviously, you're having to go back to the physician for injections periodically. Again, it's chronic dosing. In this case, the patients often get the disease in adolescence, so that if you have to go from adolescence through your entire life getting these drugs, of course, you're going to be getting many, many injections. And the cost of the current therapies is in the range of $500,000 to even $1 million a year. So over 60 years, the patients would have to pay out $60 million for that long therapy. This is where the pharmacoeconomics of a drug that's given once becomes much more attractive, particularly in young patients where you can affect and improve their life, their quality of life throughout their life. As you can imagine, these patients, since it's unpredictable when these attacks occur, they always have to be ready either to take a rescue therapy or to jump to the hospital, and it's quite a disturbing disease for that reason. Our approach here is to knock down the prekallikrein gene, KLKB1, and it's known already from antibodies that reducing the kallikrein activity can help to prevent the attacks that patients get. And again, this could be a single-dose therapy, potentially acting as a functional cure for the patients, that they may get, in some cases, no more events. There's, of course, there's a continuous reduction because the effect doesn't go up and down as you take the medication, and of course, it reduces the treatment burden. So this is a drug called 2002. In this case, the prevalence is just greater than 15,000 in the US and Europe. So, as I said, a rare disease. But it is diagnosed at a young age. So obviously a very significant effect as a lifelong disease affecting these patients. Many patients continue to get attacks despite the existing therapies. And here you see how that works to target the KLKB1 gene. It's prekallikrein that gets activated in a cascade by factor 1211, which then activates kininogen to bradykinin. Of course, bradykinin, probably know, causes vascular leakage in tissues. By reducing KLK, the prekallikrein, of course, all of these are reduced, and you can avoid these attacks. This is a trial. In this case, the modularity of our therapy is sort of very important. The only thing different in 2002 from 2001, the TTR drug, is the 20 nucleotides at the 5' end of the guide RNA. The LNP is the same, the messenger RNA is the same, and the rest of the guide's the same. With that, we were able to select doses in a very simple way. We avoided the lowest dose that we used for TTR because we knew that higher doses were safer. And we went to what was the equivalent of the 0.3 milligrams per kilogram 0.7, and 1 milligram. So 25, 50, and 75 milligrams. Also, we started with the flat dosing because we knew that weight wasn't an important factor in how these are managed. And that's probably because even though people are in very different sizes due to fat and other things, everyone's liver is actually not that different, and that is the target of the drug. When this is finished, the idea would be to do a randomized phase 2 to really establish the best dose, as well as to learn more about the safety of the drug in preparation for phase 3 studies. Key endpoints, imagine safety, the change in the enzyme. And in this case, because the attacks occur fairly continuously, we're able now to measure what the attacks are in patients because the effect is shortly after the treatment. I will show you what the effect on attacks is. Again, in terms of safety, as you might predict, it was very similar to what we saw with 2001. The main events that we saw that were related to drug were infusion-related reactions. Almost all the events, again, were mild, and there were no severe, serious adverse events, or even any grade 3 events in this case. These are, other than their attacks, these patients are relatively healthy, so they don't have any of the issues that a patient with neuropathy or heart failure might have. And this just shows the events, again, only mild, and in a few cases a moderate effect. A very well-tolerated drug. Moving to the effect, this is the reduction in kallikrein. And you can see, again, it happens very rapidly. 28 days to maybe 8 weeks is the nadir in that region. Again, it's very stable once it's achieved. So this is we predicted, again, to be permanent. And as before, at the lower doses, you get more variability. But then as you saturate, you can see you get much tighter effects in terms of the biomarker. In this case, again, getting to 92% reductions. And this shows then the effect on the attacks that patients had. And what you do at baseline, you do a period of screening to find out how many attacks they're having as they come onto the trial. And then you observe them for a period of 16 weeks after the treatment. What you see in both cases is a marked reduction in the number of attacks. Of course, if you look at weeks 1 to 5, you're going to have some attacks as the levels come down. So looking out a little further, the 5 to 16 weeks, you have about a 90% reduction in attacks. When you look at individual patients, it's actually a bit more interesting because the patients who don't have a lot of attacks to start out all went to 0 attacks very quickly, almost right after infusion or very shortly here. And for the follow-up, there have been no attacks at all following the initial treatment. The patients who had a lot of attacks, and you can see this patient has 14 attacks a month, so attack every other day in both these cases, and they've had this for many, many years. What's interesting is they didn't go to 0 for a period of weeks. And we're still, in a way, trying to understand this because, of course, their levels were down about here, and then the attacks didn't go away for longer. Talking to the physicians, these patients are used to having attacks. They don't really know what it is like not to have attacks, especially when they have them so frequently. And it may have something to do with that we're trying to explore as we go to further studies. But in any case, they've all gotten to 0 attacks. The patients who are already on prophylaxis were able to discontinue their prophylaxis, and they continue to have no attacks off the prophylaxis. I'll move next, those are the 2 knockout programs. I'll move next to advancing our insertion program. And in this case, what we see in preclinical models is that we can get high levels of protein expression. And of course, as you know, some gene therapies with AAV can dilute over time, that goes down over time. With when you alter the genome, you would not expect the protein levels to go down over time. This is how the gene insertion works. It uses the albumin locus because albumin is a very potent promoter, as you know. Albumin is the most common protein in your serum. And with that, you target in the first intron that allows you to insert a piece of DNA coming from a promoterless AAV. So this is the way you contribute DNA, come into the site, and then with that, get a stable gene insertion at the albumin locus. First disease we approached is alpha-1 antitrypsin. This is genetic disease that leads to progressive loss of lung function. Antitrypsin is as you can imagine, it's an antiprotease. If you have too much protease in your body, it leads to emphysema ultimately, particularly in smokers. The liver disease is quite different. The liver disease is due to the mutant protein that's being produced in the patients with this disease. So they have a mutant form of alpha-1 antitrypsin, and that protein gets glommed up in the liver and causes liver disease. There are many patients with this globally, over 200,000 around the world. So the approach then is a targeted insertion of alpha-1 antitrypsin into the albumin site. At the same time, we're also going to gain the capacity to knock out the mutant gene, and this is to affect the liver disease that I just mentioned. Of course, some patients have a more prominent liver disease, so this might be the most important therapy for them. Other patients don't have liver disease and have a prominent lung component. And then there are other patients who have both. You can have both damage to the liver as well as damage to the lungs. And with these two therapies given sequentially, we could approach both those problems with the two drugs. So 3001 is aiming to achieve normal human levels of alpha-1 antitrypsin. 2003, knocking out the mutant protein to avoid the liver disease that the patients get. This is what the development would look like. As you know, this would be our third knockout. We think it's very likely to work based on the other two. Again, it's a modular approach where only the 20 nucleotides targeting the gene are altered. 3001 is more complicated. We do think targeting the albumin gene to open up the site for the gene is quite straightforward, but of course it's a little more complicated to get the DNA integrated at that site. As mentioned, they can be sequenced. Ultimately, there's a very interesting area for DNA writing, and certainly as part of where we want to get to with our DNA writing program, and the best solution to this disease would be to correct the mutation, to have the gene working in its natural site, and to address the disease in that way, rather than having to do the two steps as part of the therapy. This is what we see in terms of expression in non-human primates. So again, within about 12 weeks, you see levels of alpha-1 antitrypsin that are considered normal levels of the protein. Here you see the sequential use of the knockout, and with the knockout you see the monkeys is being targeted. In this case, the monkey alpha-1 goes down to very low levels. This is how we see in vivo therapies evolving using this modular platform. Here we've unlocked part of the liver in terms of reducing a toxic protein in two diseases, and now getting ready to go after the third disease in the next year. So this we see as the first wave. As mentioned, Regeneron is also doing a very similar program to the alpha-1 to reverse hemophilia, putting in factor IX and factor VIII to treat the two types of hemophilia. But the next thing we'd really like to get to is other tissues. So LNPs are very good for getting to the liver. To get them to other tissues takes some additional work. But you can imagine diseases you may want to treat by getting to the bone marrow, to getting to the brain, and then getting to other tissues. So I want to show an example of where we are getting to the bone marrow. So I think many of you know that there's an ex vivo program that's able to treat sickle cell. This is from Vertex and CRISPR. What you do is you take the hematopoietic cells out of the patient, you edit them with CRISPR to allow them to express the fetal hemoglobin, and then give the cells back. It's worked very nicely, very exciting work. The challenge here is that you have to myeloablate the patient. This means you give them very intense chemotherapy in order to get the cells to take in the patient. So it does limit the use. It limits the use both in terms of toxicity and, of course, then the interest of patients in getting the therapy. So this will, we think, be limited to mostly selected sickle cell patients who have severe disease, but for the great bulk of patients may not be the best solution. So we would like to do this by in vivo therapy, again, giving a lipid nanoparticle that would be localized to the hematopoietic stem cells and therefore edit them in vivo way. We think that would, of course, avoid the need for the complex cell manufacturing that the other approach needs. Desirable things here are having multi-dosing here may be important because you may want to titrate the amount of editing you do in the hematopoietic stem cells or repeat it at different times. It will preserve the regenerative potential of the edited cells, and it's translatable to humans. So again, the place it wants to go, LNPs naturally, as they're mostly formed, go to the liver. What we're working on now is directing it to the bone marrow. And what we've seen is done so far in mice, so it is still early work, but we do want to translate that to non-human primates and eventually people. But you can see that you can get editing that's constant in the bone marrow cells and the hepatic stem cells over a long period of time, here over 1 year. You can also titrate this. In this case, there was repeated redosing with the LNP. With the first dose, got to about 10% editing. With 2 doses, got above the curative level needed to treat sickle cell disease. And then you can get to higher and higher levels with additional dosing. So this would be a terrific therapy for sickle cell, and hope to talk to you about this at a future meeting. So I'll end here with where we think we can go with these type of therapies. Talked about blood diseases that you can treat. Haven't talked so much about lysosomal storage disease, but you can imagine how those could be treated with a knock-in of the defective enzyme. Viral diseases like hepatitis B, if you could knock out the viral sequences in the patient. Dyslipidemias, there are companies working on PCSK9, in the case of Verve and other companies. So that certainly is a way to get a permanent treatment of that dyslipidemia. And then really to get to a lot of other important diseases, we have to get outside of the liver. Talked about bone marrow, ultimately getting to CNS. We are working on the eye through a collaboration with a company called Sparing Vision. You can imagine you may want to get to the heart as well as to skeletal muscle or diseases like muscular dystrophy. So a lot to come in this area. Obviously, we have a lot to show even for our first therapies to get them to drug approvals, but that's the plan for the next several years, and to bring a lot more to patients over the years, going beyond the liver. Thank you.
Thanks, David. Great presentation, great data. We'll have time for some questions. Maybe I thought I'd start with one, kind of a philosophical question. Permanent gene correction, permanent therapies. When you think about clinicians, what they love is control, titrating patients up, titrating them down, removing therapy, changing therapy. As a clinician, what's the barrier to adopting therapies that are permanent correction, where you lose that sense of clinical control as a physician? And is that mentality really kind of a holdover of small molecule, non-specific medications? And just curious how you think about that as a clinician, and also as it pertains to patient criteria and disease selection, as you talked about in your last slide.
Yeah, I think the most important thing I think about is what the patient wants. And the patient's looking for something that, if it's not a potential cure, it's something that gets the best effect that they can get with the drug. And that's really our goal. It's not necessary. The permanence is important. It makes it much more convenient for patients. I know I hate to take drugs, a pill every day of some sort. You sort of have to remember it. And I think for the physician, when, the type of effects we're looking at here, I think, we're very happy if our patient never has to come back to us in the case of angioedema. And some of those patients will be finished with their need to go to the allergist. They'll just go to their primary care doctor and take care of everything else. So I think I'm very excited about it as a physician, and even if I needed these for myself, I'm excited what they could do for patients.
Great. Let me open it up. Anastasia. Somebody else?
Okay. So the question is, you demonstrated some impressive bone marrow delivery. So what is the difference in liposome formulation which you use for liver delivery versus bone marrow delivery, and what % of injected dose actually goes to bone marrow?
Yeah. I have to say I actually don't know. They're trying. I mean, they try different things. It's modified. Some of the ideas that are out there, it will probably still go some to the liver, but of course, editing this gene in the liver, as long as you get enough drug to the bone marrow, is okay, because it's not expressed in the liver. But some of the ideas out there are using peptides, antibodies, all kinds of things. And we're not talking yet publicly about how we're doing it.
You say, just to follow, can you say anything about the dose levels? I noticed you didn't have dose levels there.
Yeah, it's not different in terms of LNP to the kind of dose ranges I've been showing you. Yeah.
We'll go here and then here.
Yeah, really nice data, I think. I was really surprised by the level of knockdown you get. It seems that almost 100%. Does that mean that almost every cell is edited in the target tissue? And a follow-up question, I know that at least in the lab, knock-in is usually less effective. Now the question, if you go to a knock-in of a tissue, let's say stem cells in a tissue, and you titrate it, can the level of knock-in change over time, over years, when the stem cells are populating or regenerating?
Yeah. So we do think we're pretty much hitting every hepatocyte with those things. The TTR is produced elsewhere in the body, in the eye and the brain, so we're not sure if even the residual TTR is not even coming from the liver, but it's a very high percentage of the liver is being edited. And we were obviously, very, very, I guess not surprised. That's what we had seen in non-human primates, as you saw, and it was replicated in people. So it is a good result. I did mention we went to a slightly lower dose than the highest dose. And, of course, since they look the same, you would always choose the lower dose as being potentially safer in some way, even though we didn't see any significant difference in the safety. The other question was about the...
with the knock-in, If you don't knock in it to 100% of the cells, would it change over time?
No, so you don't want to knock in 100% of the cells because you still need your albumin. So with knock-in, it is hard to, you're probably getting a much smaller percentage of effective ones. You're going to get indels probably throughout the cells, but it's in an intron, I think you saw, or maybe it didn't show it, but it's in an area that doesn't affect the sequence of the albumin. So most of the albumin can still be produced, even though the gene has been edited at one site. But the knock-in, you don't need 100% to get the kind of levels we saw because it's not as abundant a protein as albumin. So you can get very high levels, normal levels, without getting most of the albumin edited.
So, kind of related about the albumin insertion, I didn't catch, so I guess two parts of the question. So, what is the delivery system here? Because is it more lung specific or affects the lungs, right?
Oh, the liver, the knock-in?
Yes,
so the knock-in, So the lung is what you're protecting. So alpha-1 antitrypsin is again a liver-produced protein. In its mutant form, it causes liver disease. That's why you want to knock it out. But when it doesn't get into, it's a serum protein that through the serum protects the lung from proteases. So it's by its name
So just that it goes to it's indirect.
Yeah, so you protect the lung by affecting the liver.
And this related question is, so this is DNA at this that you're delivering.
Yeah.
So do you see any immunogenic effects or
it's
RNA? On DNA, what kind of DNA is?
Oh no, so it's RNA. So it's messenger RNA for CRISPR-Cas9, and it's a guide RNA that brings the CRISPR-Cas9 to a single place. So all the work that we do, the most work we have to do is on off-target. It's the biggest question people have. Are you going to hit other places in the genome? Is that going to be a problem? What we see so far is we would predict not to hit other places, even when you push the dose. But we'll be following the patients for 15 years. All the genes that we identified, even if we hit them, are not things that would be a problem for the patients from what we understand. So we feel very good that this will be safe, but obviously we have to prove that over many years.
Maybe just to clarify, the insertion template is DNA.
The insertion template is, The insertion template is DNA. So it's a AAV that has the alpha-1 antitrypsin gene in it. So, and that gets inserted into that albumin site.
So you don't see any immunogenic issue with that DNA?
No, that DNA from the AAV is wild type, and we haven't seen it mutated in this process. Yeah.
Great talk. I just had one question about the hematopoietic stem cells because it's really impressive. But you do multi-dosing, so you do repeat dosing with your Cas9. So is that really clinically viable long term since it has a bacterial origin? Isn't it the risk for T-cell response if you do multi-dosing?
So the messenger RNA is gone, right, in a few days. Oh, you're worried about whether you're going to
you get proteins that are presented.
You do get anti-Cas9. You can get anti-Cas9 antibodies. They don't do much. It's only there for a few days, and it is, presumably...
And no T-cell response?
No significant that's been seen, yeah. And you can imagine it's probably because it's being expressed for so little time.
Yeah, but it's going to be expressed at pretty high levels for a short time.
Yeah.
And you do it, and you're off, and then you introduce it again, so I think,
Yeah, no, there is a potential that has to be looked at for sure. This hasn't been seen so far.
I know.
You mentioned about the transient expression of the Cas9. What is the level of stability you need for the guide RNA if that's the case? Yeah. We worry about the chemical modifications and all that. Along the same lines, it seems like just for that, you don't need much. What do you use?
Yeah. You don't need much guide?
No, the stability or modification.
Oh, yeah, you don't need much. It is modified, obviously, to avoid, stimulating immune, responses, etc. But it's, again, I guess it's proprietary. But the observation is that it's as you can see, very effective in those quantities. But yeah. But maybe I missed the question of what you're wondering if the.
I think in your introduction, maybe not to help out, but you're creating RNA guide complexes in the cytoplasm. So the mRNA expression of Cas9 comes up probably within minutes to hours.
Oh, when do you see it? Yeah, it's probably edited in the first day.
So you may get some chaperoning effects of the guide in that time frame too. So you may not need like days long of guide RNA.
Yeah. No, it's very immediate.
Sorry, I'm answering.
Yeah, thank you.
I don't work for these guys, just.
But yeah.
So for the liver. Hi. So for the knock-in, I'm just curious, why are you using AAV? Is there problems with co-formulating the DNA into your LNPs?
Wait, getting the DNA. What is the question? Oh, sorry.
Why are you using the AAV as a donor template for your knock-in?
Because there aren't other good donors to donate in the nucleus. I'm sure Matt can tell us that.
I'll talk about that in depth tomorrow.
Yeah. People obviously want non-viral systems. So anyone who has a non-viral system, come around and love to have it. But, AAV is a pain in the neck, but it's effective in that use. Yeah.
So just what?
Oh, sorry. Yeah, thank you. Since you just mentioned AAV, so like AAV to target liver, previously showed that for hemophilia treatment after, so the therapeutic effect will decrease gradually year by year. And then here, when you use the MP to target liver, seems the knockdown or knockout effect is really kind of permanent. But then the liver or hepatocytes normally has a relatively short turnover rate or lifespan. So did you check whether RNP CRISPR can also edit the liver progenitor cells? Then that can really explain why the therapeutic effect really kind of looks permanent.
Yeah, no, we've looked at that carefully. I mean, there are a few pieces of it. So the AAV itself will be there for a long time, and when you use it for knock-in, it's a promoterless AAV. So, if it integrates, it would cause less problems than other AAVs. But the fundamental experiment we've done is we've knocked out a gene in a mouse. So we edited the liver. You can then cut out 2/3 of the liver and let it grow back. And when it grows back, it's fully edited. So it doesn't seem, if there's a progenitor, we seem to be hitting it with the LNP. Yeah.
First, with regard to off targets, do you see in the future any more permissiveness or tolerance for potential off targets from these therapies? I know right now we all say that off targets are zero, but in some cases this may not always be the case, especially when we go to a sort of more restrictive genome editing modality. So do you foresee anything that would make us believe that we can be a bit more permissive other than saying there's zero off targets?
Yeah, we think it's possible. Obviously our goal is always to have basically zero off targets. Obviously the genome does know how to deal with lots of hits at different times. But if you did hit, something like a suppressor gene and knocked it out, that would be bad, for example. But I think there are things where you might find, a little higher editing in a particular gene, and you could test whether that makes any difference. And one way to do that would be to make a very good guide RNA for that particular gene and see what the effect of knocking out that gene is. So we've looked at things like that. Yeah.
I think we have two questions coming in virtually, so great to get participation from our virtual crowd. We know they're there. So maybe we'll take those two calls and two questions and then call it an evening. Sound good?
So the first one is, how are you thinking about gene editing in the pediatric population or also the female patients of reproductive potential who are not included in the clinical trial for her knowledge?
Yeah, both very good questions. In the pediatric population, it actually is really exciting because, unlike gene therapy, you have all those years in a pediatric population to get diluted out, so you could have a permanent effect in certain diseases. And one we're very excited, of course, it would be hemophilia, getting to younger and younger patients with the hemophilia program, because that's when most of their problems come at a young age with hemophilia. Again, if we can do everything we can to have a safe therapy based on what we do preclinically, what we're learning clinically, we do feel good about moving this to younger populations where they need it in diseases like hemophilia. For women of childbearing potential, we have done studies. We're going to talk about them publicly soon, but we don't see any editing in progeny, even pushing doses. But we'll be talking more about exact experiments soon. We are treating women of childbearing potential in our studies. We brought the data that we have in breeding studies to health authorities in Europe and New Zealand, and we're going forward. We have treated women of childbearing potential. So we think, again, the risk from what we know from the studies is very low. The other thing is none of these genes are expressed in the ovary, but of course, if you hit an ovum, you wouldn't want to do that. Yeah.
The second question is for AATD insertion treatment. What is the consideration behind using AAV to deliver insertion template instead of the LNPs? Sorry if you already answered it. I tried.
No, it's all right. Yeah.
Give the answer back.
Come to my talk tomorrow. I'll spend all 25 minutes talking about that, more or less.
Yeah, you really need the DNA in a particular form to get it into the nucleus, basically.
We'll have a brief tutorial on DNA innate immunity tomorrow. So,
great.
All right, I think we're... All right, Shalene.
Get the philosophy.
So I think this is quite very important and very interesting to see that fusion is also. So do you envisage that is the size of more off-target effect or variation? What's your thinking around that? I don't know that you have an answer to that, but
right.
Just to have.
Well, in first principles, having more, bigger population, you have more chances, more chances that something may happen. But that's the idea of spending a lot of time choosing the guide that you feel that you won't get those off targets. You stay to as low a dose as you can, again, for the reasons that at low doses, you don't see, when you pick the guide appropriately, you don't see the off targets. And again, the off targets, even when we look at the type of genes that are predicted based on hitting naked DNA, they're not genes that would really be a problem for the patient, even if a few of the cells were altered. So looking at the whole picture, we think the risk is really quite low, but we're going to people will keep asking us until we prove that, obviously, over time. But that's, a lot of, and you probably saw out in the literature for a while, people were talking about chromosomes falling apart with CRISPR and things. And a lot of that was likely picking, either if you do hit multiple places, you start to get rearrangements of genes. If your guide isn't specific, you are going to start to get some changes. But that's the idea is to not do that. And so that has to do with choosing the right guide RNAs.
Thank you, David. Okay. Great talk. And again, just join me in thanking David for sharing.